Welcome to this medicine masterclass on acromegaly. This is a condition that results from increased secretion of growth hormone, usually from a pituitary tumour. Other causes include pituitary hyperplasia and rarely an ectopic growth hormone secretion from a carcinoid tumour. Growth hormone in excess stimulates bone and soft tissues through the action of insulin growth factor 1. The presentation, the features, if we take a head-to-toe approach, the patient may appear to have enlarged supraorbital ridges. They may complain of bitemporal hemianopia, that's loss of vision in the peripheries. They may appear sweaty. They may have a large nose, large tongue and widely spaced teeth with prognathism or protrusion of the lower jaw. The patient may have goiter as a consequence of organomegaly due to the growth hormone. They may complain of snoring due to the enlargement of the adenoids. Their hands and feet may be disproportionately big, and they may complain of joint pains and carpal tunnel syndrome. Females may complain of amenorrhea and males decreased libido. The complications of excess growth hormone include impaired glucose tolerance and possibly the development of diabetes, hypertension, obstructive sleep apnea, organomegaly. For example, in cardiac disease, this may lead to cardiomyopathy. The acceleration of cardiovascular disease, including ischemic heart disease, arrhythmias and stroke, as well as an increased risk of colonic cancer. And colonoscopy screening is advised for patients with acromegaly. The important investigations, an oral glucose tolerance test may be helpful. This may fail to suppress growth hormones in response to glucose. In contrast, a normal response is growth hormone suppression to an undetectable level following the administration of oral glucose. Moreover, insulin growth factor 1 is a useful test to perform. In acromegalics, this is invariably elevated. It's important to image the pituitary gland with an MRI looking for an adenoma. If it's a microadenoma, it may not cause compression of the optic chiasm and patients may not have peripheral visual defects, but if it's a macroadenoma, a large tumour, this may cause chiasmic compression and the patient may complain of bitemporal hemianopic symptoms. Surgery is the first-line management. A transsphenoidal resection of the pituitary adenoma or medical therapy such as somatostatin analogues which block growth hormone secretion such as octreotide or lanreotide are helpful, or a direct growth hormone antagonist if the patient has resistance to somatostatin analogues such as pegvisomant can be used. If surgery is contraindicated, the patient may undergo radiotherapy. The choice of management is a multidisciplinary team decision using a patient-centered approach. Thank you for attending this medicine masterclass.